Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Block 9 Trauma, Episode 3, Burns in the Older Adult. After viewing this episode, participants will review the characteristics of burns in the older adult. Participants will understand how older adults are impacted by burns. Finally, participants will review the treatments of burn injuries in older adults.
I responded to a scene in which two elderly patients were in a house that blew up, in which one was thrown clear and one was actually trapped in the fire for a period of time. They were both very concerned about each other. They'd been together for a very long time. The initial patient was an 83-year-old female who had 90% burns to her body, second and third degree. She was conscious, alert. She had multiple trauma from the explosion, with possible fractures and such. She was maintaining her airway at that point. We gave her oxygen. We immobilized her because of the blast injury. Bandaged her large gash in her arm that had come out, and proceeded to try to treat her burns as best we could and get her to a trauma center. I had transferred care to another crew, and then I proceeded to take care of her husband, who was 99% third degree burns. He was conscious and alert at the time. He was maintaining his airway at that time, but he needed definitive airway care due to the fact that he had soot in the airway and was prone to having swelling of the airway immediately. So he was transferred to the closest facility, at which point he was received an airway after having to have a cut down to get vascular access, and then I transferred him to the burn center for further treatment.
Well, elderly burn outcome is worse, and a lot of it is in burn patients is worse than in the equivalent size burn in a younger patient, and that's for a number of reasons. One is the physiologic changes of aging, the cardiopulmonary changes that happen as you age. For large burns, it's a high volume resuscitation, which an elderly person may not tolerate as well. They don't have the cardiac reserve. They end up with pulmonary edema on the ventilator with a lot more complications than the younger patients do. But outside just the resuscitative issues in an elderly burn patient, their skin turgor is a challenge. They're more likely to suffer deeper burns. You lose a lot of your subcutaneous fat, your dermis thins out as you age, your epidermis is a lot more friable. So in those areas that get burned, they tend to be deeper, and it's harder to graft those burns. In order to skin graft somebody's burn, you need to be able to take skin from another area, which in an older person, the quality of that skin you take, and it's you don't take a full thickness layer of skin. So the way you do a skin graft is you basically shave off a thin layer of the skin just down to the dermis, and the donor sites don't heal as well, and the skin that you're able to graft isn't as good quality as when you're younger, so the grafts don't take as well. So resuscitative complications, they don't survive, they don't heal their burns as well, and their burns tend to be more significant and deeper. Any component of inhalation with their baseline pulmonary issues in an elderly patient is always worse than in a younger person.
Burns in the older adult tend to have worse outcomes. Physiologic changes in the cardiac and pulmonary systems reduce the ability to survive and recover from burns. Changes in the skin predispose older adults to have deeper and more severe burns. Due to skin changes, donor sites for skin grafts are harder to find. Skin grafts are not as successful in the older adult.
Burn patients are triaged in the order of airway, breathing, and circulation. Are the injuries impinging on their airway? If so, that's the first priority. And are they having problems breathing from smoke inhalation, or is this an isolated burn to an extremity? The treatment of the burn itself is based on the severity of the burn, first degree, second degree, third degree, at which point the burning process is stopped either through cooling or dousing with water, dried, and then dry bandaging placed upon it and transport. Additional steps are to start invasive lines, ECG monitoring, and oxygenation, and then transport to an appropriate burn facility.
Geriatric burn patients, that falls under some of the ABA criteria to send them to a burn center rather than extremes of age with a greater than 10% burn. So second degree or higher burn should absolutely go to a burn center. What I think sometimes isn't realized as much on the EMS level is if they get sent to a smaller hospital, eventually they will end up at the burn center, but that will end up 5 and 6 hours later, which actually worsens their outcome. Any hand burn should go to a burn center. Any perineal burn should go to a burn center. Any significant hand burn and any perineal burn should go to the burn center. Any burn over 10% should go to a burn center. And in extremes of age, more likely you're going to come to a burn center.
Burns are triaged by type, severity of burn, and percent of burn using the rule of nines. Criteria for transportation to a burn center includes the extremes of age, second or third degree burns greater than 10% of the body, or burns that involve special areas such as the perineum and hands. Any burn that has immediate life-threatening characteristics should be transported to a local facility first.
The overall treatment of the burns themselves is not different. You may be much more aggressive in your treatment of elderly because of the fact that their morbidity is going to be higher based on a lower percentage of burn. Because they are more prone to infection, they have a decreased immune response, decreased cardiac response. Therefore, their ability to cope and manage these things is something you have to take into account in your treatment of them.
So if you look at burn patients, the main thing is to stop the burning process. So if you come upon someone who is still on fire, you know, what we all learned when we were kids, stop, drop, and roll. But you're going to be doing the stop, dropping, and rolling for them, putting the fire out. If they have a chemical burn, washing that with water, not with some other chemical to neutralize it. That will actually make it worse. It'll cause an exothermic reaction or it'll create heat. So you're just going to rinse that off. If it is a dry substance that is causing a contact burn, you're going to brush that off. You're not going to wet it. Sometimes that'll activate things. In the field, the most important thing you can do for an older person is stop the burning process. Their skin's going to be tender, but a clean, preferably just dry gauze around it. Not wrapping them in soaking wet gauze because they'll get hypothermic, and maintaining normothermia in this patient. So stop the burning process, cover the burns with clean gauze, keep them warm, and get them to a burn center.
Be very aggressive in their airway management. They will decompensate on you very quickly. Maintain their temperature as best you can. Be very detailed and thorough in your assessment of them. Try to determine what their comorbidities are, as those will be issues that will come back to haunt you if you get behind on them. If you don't realize that they're diabetic or that they have a heart condition, when you're treating them, all of a sudden things will crop up and suddenly they will get very, very sick on you very quickly, and if you haven't anticipated that, you may not be able to catch up. Pain management is important in all patients. Again, the elderly, you have to be more aggressive in your questioning to determine if they're actually experiencing the pain. They will minimize what they are feeling to you because they don't want to be a bother or such. But you do need to give them pain medication and get them feeling better, because that can have other responses to the body with the pain, and you want to minimize those effects as much as possible.
Burns are very painful, but with a grain of caution. That older person isn't going to metabolize that narcotic as quickly as a younger person is. You're going to want to be using shorter acting agents. You're going to be a little bit careful about your own polypharmacy with the geriatric patient. Small doses of morphine to control these patients' pain is appropriate, but you'll be more likely to communicate with your medical directors about any significant dosing of intravenous pain medication in a geriatric patient.
The pre-hospital management for burns includes stopping the burning process. For thermal burns, deluge with water. Chemical burns can also be deluged with water unless otherwise specified. Dry chemicals should be brushed off. Remove contaminated clothing. Cover the burn sites with a dry, sterile dressing. Monitor baseline medical conditions, i.e. blood glucoses. ALS can start IV lines and monitor EKGs. Keep patients warm to prevent hypothermia. After viewing this episode, participants will review the characteristics of burns in the older adult. Participants will understand how older adults are impacted by burns. Finally, participants will review the treatments of burn injuries in older adults.